Okay, this afternoon I just wanted to go through the physiotherapy management for osteoarthritis in the knee. And basically when you send a patient for physiotherapy, what we have and what we do is we have a whole range of techniques that we use mainly for these these three outcomes that we hope to achieve, which is pain, reduction of pain, and basically is to eliminate pain. And various techniques have been researched, but I must say that the research still needs to be, more needs to be done. And in order to come out to the collation of all these studies, I've actually enlisted 12 other physiotherapists from the various public as well as private sector practices as well. So I'd like to, and the acknowledgement of these people are in the booklet as well. Okay, so basically I'll go through some of the techniques that we use for pain reduction. And the other techniques that we use, especially in exercise, is to improve their function and also to do some joint alignment. Now, there's not much that can be realigned if there's joint changes already, but with weight reduction, we may be able to see some of these changes. And of course, we have braces and taping and things like that as well. So basically, a lot of our aim of treatment is to improve their muscle function, hopefully to realign some of the joints, range of motion, to improve the range of motion. A lot of them come with tightness and in the muscles especially, and that again affects them. So a lot of the physical function and their ability to continue with their activities of daily living is also another aim of physical therapy. So finally, we want to reduce and delay progression of joint destruction. So before we discharge our patient, and something that I didn't really put down as a modality, but education. In physiotherapy, we see our patients at least 6 to 10 times before we're ready to discharge, our patients are ready to be discharged. And a lot of education goes into these sessions because the patient ultimately has to learn to manage. And what we found is that a patient that is very well educated, having the ability to know the boundaries or the parameters, when to do more, when to do less, how to manage their pain, either with medication or without medication, when to wean off some of these medication. These are things that sometimes the patient has to learn to manage on a day-to-day basis. So we try to do some of that education as well. So basically, the different modalities that I'll go through will be exercises, both in these are the ones that has evidence for reducing pain or improving function and even endurance and fitness as well. Weight reduction, electrical stimulation, bracing, taping, manual therapy, acupuncture, and some of the other modalities. Now, you'll be surprised at some of the ones that that a lot of patients say, oh, it makes me feel better, we get immediate relief of pain. Currently, there's not a lot of evidence for them, but anyway, we still continue to use them. So exercise, of all the modalities that we use, exercise is very well researched, and there's a lot of RCTs on that to improve mainly to improve functional activity. But because of this improvement in functional activity, you'll find that it's very much related to their pain levels as well. Also, with exercise, your release of endorphins, especially if they exercise for more than 30 minutes, if they're able to maintain an exercise for more than 30 minutes with the release of endorphins and things like that, you'll find that the patient actually feels better. Of course, the key function of exercise would be to help them to reduce weight as well. So with the combination of diet, you find that the relief of pain and the function and the improvement of function is much better. So as I was sharing, it's not just telling the patient to go home and exercise. So in physiotherapy, the key thing is teaching them how to exercise. What's the correct way to exercise? What they can do and what they can't do. It's not enough to just tell the patient to go home and do more exercise. Really, it's more teaching them specifically a lot of the non-weight bearing exercises. And if you needed to help them lose weight, then they need to find aerobic type exercises that they can do, which is in a non-weight bearing position. So in trying to help them lose weight, what we hope to continue to encourage them to do is hydrotherapy, which I'll talk about, which I'll talk a little bit more later on. Basically, some of the studies have found that if you can encourage weight loss, you can get even 6% of weight loss. You can get significant improvements in the joint biomechanics as well as the functional improvement. Okay, and then they've also shown using X-ray studies as well, that the medial joint space can improve with weight loss. In Felsen et al. In 2000, what they found was that even with at least 5 kilogram weight loss, the odds ratio was much better, 50% significantly better. When we manage our patients with OA, they usually have an obesity or a BMI issue as well. So a lot of the advice and the exercise in long-term management really is to help them manage this weight issue, which can be quite a difficult thing for them because when you're trying to just exercise to lose weight and you have arthritis as well, it's hard to get the right kind of exercise to burn off enough calories. So diet is a very key factor in combination with the exercise. Okay, hydrotherapy has been strongly evidenced for helping people with OA, mainly I think because of the fact that it's non-weight bearing. Plus, with the resistance, you can really get the calorie burning exercise that you need for these patients who need to lose weight. Okay, of course, there's a strengthening effect that comes with exercising, even in water-based exercises. Okay, now we come to the more, pain, what we call electrophysical agents, more pain-relieving type techniques that we use in physiotherapy, which is the TENS, transcutaneous electrical nerve stimulation. Basically, a lot of these work on pain by using a pain closing the pain gate theory. So they stimulate the A delta fibers, and these fibers actually close the gate. Your C fibers open them, and so the TNS with the prickling sensation helps closes the gate. So a lot of patients get immediate pain relief after these sessions. However, how long this pain relief lasts, unfortunately, is not sustained. And so a lot of our techniques for pain relieving are always done together in addition with exercise, because without the effects of strengthening the joints, especially the knee is a weight-bearing joint, without the effects of strengthening or realigning some of these joints, it's hard to maintain that pain relieving effect. Whether with pharmacology or just using short-term pain relieving techniques like TENS, you really need to have that combination of exercise. So therefore, for physiotherapy, when you send a patient for physiotherapy, you'll be very assured that they will definitely get a series of advice on what to do and how to exercise, besides using these techniques. So again, it's not just enough to just send the patient home with a TENS machine and say, okay, every time you feel pain, put on a burst of TENS. It's really, again, my message is that in physiotherapy and for patients with OA, it's the exercise component that really must kick in for the long-term management for pain. Okay, interferential current is just another form of TENS, and in fact, these currents are delivered at a more comfortable rate to the patient. TENS, sometimes some patients might feel that the prickling sensation is too sharp, not comfortable. The interferential current is a little bit better in delivering sensory doses or high frequency doses to get the same pain gate effect on the sensory nerves without the uncomfortable feeling on the skin. So this is an interferential current therapy that's given for shoulder pain. We also have taping. Again, a lot of taping is done to help do some shift in the joint alignment. So like for chondromalacia, if one muscle is, if the medialis is weak and the lateralis is tight, there's a shift of the patella. We use the tape to try and shift that and then encourage them to exercise. Once we strengthen the muscles, then we can remove the tape, and then hopefully the patient can take over that, maintaining that correct alignment as they move. Okay, braces and wedges have been tried as well. For those who have very marked malalignment, we do encourage them to get some of these braces, and some of them can be bought off the shelf. Some needs to be custom made, and usually we will send them to a podiatrist to help custom make some of these wedges. Braces also have been found to be useful, especially for patients who again have quite marked malalignment. However, these braces are quite expensive. You're looking at about 300 to 400 Sing for the simple ones, and of course the more complicated ones can be even up to $1,000. So, but they have shown that these braces can relieve joint compression in the medial aspect. Manual therapy has been done. Again, the mechanism of action for manual therapy is we do joint mobilization, and what we found is that with the joint capsule, the proprioceptors and the receptors in the joint capsules, when you mobilize them, when they're not in a stretched position by swelling or inflammation, they do send signals which can help relieve pain sensation. So again, this is another technique that we use to get immediate pain relief so that we can work with the patient and encourage them to exercise. So you see a lot of the physiotherapy techniques, our first line of treatment is to get the pain relief, either an immediate pain relief. Hopefully some of these will be sustained. And sometimes OA patient, they have habitual, what we call habitual pain sensation, meaning they've had this for so long, it's a chronic pain thing. What they sometimes need is for us to change that pain sensation at the dorsal nerve root, or just to change some of the interneuron signaling. So once you're able to continually relieve them of that pain or teach them how to relieve their pain immediately when it comes, it actually stops the chronicity of this pain sensation, which gets triggered by any emotional or any incident that comes on. Okay, so manual therapy is something that we use for joint mobilization, and again, the effect is really through the joint proprioceptors. Of course, if there are adhesions in the joint capsule, again, that's where we help to relieve some of that to encourage the range that needs to come. As I said, there are less evidence for things like thermotherapy, heat, which we use quite a lot, and patients all, would first thing they ask for is to have a hot pack or to have some shockwave on their knee to relieve their pain. And they do get the immediate pain relief from the sensory nerve that is stimulated. But research has shown that it's not long-lasting. It's not more beneficial compared to other techniques that we use. So again, whether should we continue to use them or not, but you'll find that in most therapy sessions now, we tend not to use a lot of heat unless the patient insists on that. So these are some of the shortwave diathermy units that we have. We also use ultrasound, especially for if the patient has a lot of stiffness or adhesions and scarring. Ultrasound has been found to be able to reduce scarring and to realign collagen fibers, increase blood flow to the area, especially for areas where there's not a lot of blood flow to the tissue. Ultrasound has been shown to improve localized increased blood flow to the tissues. So again, ice therapy, in fact, ice therapy has immediate pain relief, and that has evidence. Acupuncture has also been quite widely researched. There's a lot of evidence for using acupuncture to relieve pain. My message, you can relieve the pain, but unless you get to the root of the problem, which is the muscle alignment and the strength and the range of motion, that's only just one aspect. And Tai Chi with, there's only one RCT currently, but there's a lot of Tai Chi groups helping, working with OA patients as well. So our recommendation is that, yes, there's a lot of physiotherapy techniques are useful, especially for immediate pain relief. Right, but I think for the long-term pain relief really is to improve their muscle function, their alignment, helping them to cope, educating them on how to do their own immediate pain relief using simple things like ice or heat or using electrical stimulators. But more importantly, making sure that they exercise, either to reduce weight, to strengthen their muscles, or to realign either by taping or bracing for those joints that are really out. Okay, so there are there's lots of alternative therapies out there, and I think the Chinese medical, traditional Chinese medicine also does Tui Na and things like that, which sometimes the techniques are fairly similar with physiotherapy. Again, they're using a lot of massage for pain relief. But again, the take-home message is these people, if they're overweight, they need to lose weight. If they have physical dysfunction, then you need to improve that physical dysfunction in the long term. Thank you.